Good afternoon and welcome. Thank you all for joining us today. I'm Samantha and I'm the Director of Member and Partner Services for the Florida Association of ACOs. We are excited for this opportunity to present to you our next installment of our webinar series, Home as the New Care Setting. Are you ready? Before we get started, I'd like to go over a few items so you know how to participate in today's event. You will see a user control panel at the bottom of your screen. You can listen in via your computer speakers, or if you'd prefer to join over the phone, just choose dial in when logging on. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions tab. You may send in your questions at any time during today's presentation. We will collect these and address them during the Q&A session at the end of today's presentation. With that, we will get the presentation started.
Thanks, Samantha, for the introduction, and welcome to all of the members of the Florida Association of ACOs. We're delighted to be here today to discuss this really important topic around the home becoming a new and emerging care setting that is just critically important in today's healthcare delivery environment. Really excited to introduce two of my co-panelists, but first I'm Ashish. I'm the CEO and co-founder of Dina, a digital healthcare company, working with ACOs, health plans, and large provider groups to really partner with the home-based care continuum. And I'm also joined by Dr. Marianne Laletta, Chief Medical Officer for Dina. Marianne had joined Dina by way of her most recent role was Executive Medical Director for Inspira Health Systems Life and PACE programs. And then prior to that, the Vice President of Medical Operations for Jefferson, New Jersey, which is part of the broader Jefferson Health system, which is now north of 18 hospitals in the greater Philadelphia, New Jersey market. I'm also pleased to announce that we're joined by Tina Burbine, Vice President of Care Innovation at HealthLink Advisors. Tina has an incredible track record of over 25 years in healthcare and IT, serving as a trusted advisor for numerous ACOs, health systems, and plans as they embark on numerous transformational changes that are right here in front of us. Also, most notably, HealthLink Advisors was just recently received a prestigious recognition by Class Research as one of the top-ranked strategic IT advisory services companies out there. So, Tina, thank you again for making the time to join us for this important discussion today.
Yeah, happy to be here. Thank you.
So let's set the stage for today's conversation. What we're really hoping to accomplish today is really a few things. First, really touch on some of the key industry trends that are really driving this transition to home and virtual-based care and how it ultimately impacts ACOs and other large provider organizations. We want to drill down specifically on 4 specific strategies that ACOs should be considering as they think about this post-COVID operating environment and how to ultimately be successful. I'm really excited for this part of the discussion. The panelists have really done a nice job preparing. And then we definitely want to make time to address any questions from the audience. There is a Q&A function within Zoom that Samantha took us through. So please don't hesitate to address that. And if we can't cover all the questions today, we will be sharing our contact information. We'll work with Flacos to ensure that we get written responses out. We want to make sure that this is worth your time and effort for joining. So with that, excited to jump in. Thank you all for taking the time out of your busy schedules to participate in this incredible discussion. So, just to kick things off, Tina, I want to bring you into the discussion right out of the gate, because you have the benefit of working with many large provider groups, ACOs, and health plans, in particular executive teams, as they sort of evaluate what's happening in the market. And a lot has happened leading up to COVID, then COVID, and now sort of in a new post-COVID operating environment. I would love it if you took a few moments just to sort of highlight some of the key trends that organizations are thinking about in their boardrooms.
Yeah, thanks for that. Gosh, there have been so many catalysts that have helped shift care into the home over the past few years. And it starts with our payers who have entered, care in the home by acquiring large home health companies. Humana acquired a home health organization, making them the largest provider of home health care services in the US back in 2021. And United Health followed suit by announcing an acquisition just a few weeks ago that set a record, I think, for about $5.5 billion to compete with them. And that's positioning our payers to begin offering care in the home services to all of their members. So we have this shift in the payer market, and that combined with other catalysts that we have across the industry, like the emergence of new technology and capabilities, our growing investment in digital health, virtual health, and of course now a consumer-driven market with our patients asking for care in their own homes. So all of those factors have converged to create for the first time a willingness to shift our authorization rules, our plan and benefit design, so that we can serve patients in the home. And now our provider organizations are putting programs into place to adapt to that as well. So it's exciting.
There is absolutely, from your point, a lot of change. And one of the things that we're observing in the market is that every provider organization, much like they adopted virtual care technologies, is thinking about how do I deliver care in person, online, but also bring it to you in your living room as a preferred site of care if it's safe and reliable. I know,
right.
Marianne, that's something that we're going to talk a little bit about just based on your experience. So no doubt there's a lot of changes in flight right now in the market. Marianne, maybe this is a place where we can kind of jump right into the meat here of the discussion, just given that context of what's happening in the broader payer landscape, how providers are starting to think about the home as a and post-acute setting as a care setting. What are some key strategies that ACOs can start to think through, given some of the market conditions, to ensure that they're positioned for success, not only in this operating year, but subsequent operating years as well?
Sure. I think in leading up to this, thinking of 4 anchors that we can really ground the conversation around, creating some visibility into the post-acute care facility-based utilization patterns of the ACO. Now, I know everyone does this. We track and trend and monitor, but having visibility really alone isn't enough. You need to find ways to create partnerships with those post-acute facilities, as well as have a means of real-time communication so that you can gain some insights and create actions based on the information that you're receiving. So it really is more of a connectivity and partnership that is needed beyond just the visibility and the tracking and trending of results. You also need to work on building the preferred network of home-based providers and help create visibility into that care, which can be very challenging. Many of the home-based providers you may be interacting with are not necessarily rated by CMS. They are not necessarily owned and operated by your organization. You need to have some influence over those providers, but you don't have direct control. So how do you create that connectivity so that you can influence decisions that are being made in the home or care that's being provided? Third, establish direct connections to the members at home to drive timely interventions. I know many of us in the healthcare industry for years have been trying to do telephonic interventions for people status post-acute illness. But we also need to think beyond those telephonic communications, because oftentimes patients don't respond. There's challenges reaching them. You end up playing phone tag, creates a lot of frustration for all those involved. And beyond that, we also need to think about connectivity to your patients or members at home, not just status post and acute illness, but also in times of wellness to maintain wellness and keep them connected to appropriate care at the appropriate time, in addition to chronic disease management possibilities. And finally, scale with technology to manage by exception. We all know that we're struggling with staff shortages, problems with staff burnout. How do we enable ourselves and our teams to extend our reach without feeling overburdened or pushed beyond capacity?
Yeah, such an important point, that last one in particular, especially given what's happening with the workforce, as you mentioned, and the shortages and the stresses of, more there are more people to care for than ever before with fewer resources available. So this is something that we hear quite frequently in the market as well. I did want to share with our audience today that when I hear you describe these 4 strategies, I know that Marianne, you and I have had a discussion around this, but it really reminds me of a metaphor around care traffic control. If you think about air traffic control towers, and their role of making sure that planes are able to take off, follow a flight pattern, and ultimately arrive at their destination safely. And sometimes there are adjustments that need to be made in flight. I sort of think about these strategies as almost setting up a air traffic control tower in every community where you have visibility into what's happening as it relates to an individual's care journey, and making sure that they take off, navigate their journey, and ultimately land in real time. So something that obviously is really core to what we do at DINA, but I think critical in terms of I think we're going to start to see air traffic control towers pop up in every community as care shifts outside of the four walls of the traditional healthcare environment. So just a fun sort of visual for us to kind of get the conversation rolling. You know, I do want to kind of jump right into it and dive into this first topic. And for the audience, we'll explain these charts. That it's not, I promise you, it's not an eye chart test here. But Tina, I wanted to pull you into the discussion here specifically around this first strategy of optimizing your post-acute care, but specifically around skilled nursing facilities for the members within your ACO. And so I'm assuming by now that most ACOs have built some form of a preferred or high quality network. Just to level set the audience, can you describe sort of what goes into building a high quality network of partners in the post-acute space?
Yeah, absolutely. And you're right. Most ACOs have relationships with high quality SNFs because it's a big part of ensuring that their patients are well cared for. Those that have really strong programs are focused on, improving medication safety. They're preventing proactively infections, and they're able to drive programs like antibiotic stewardship. Teams are actively working to improve patient mobility to prevent falls and pressure ulcers. And they're recognizing very early the signs of change in a patient's condition. And when a SNF team can do that really effectively, it means that it's, there's a reduction of ED visits and hospital admissions and readmissions, of course. The other thing that we've noticed with really strong SNFs over the last few years is this trend where SNF care teams are being embedded into the care plan process and care transition planning between the ACOs and any health systems they serve. Traditionally, we know that the SNF environment has been another area of siloed care. And so to be able to see that teams are making this intentional workflow and care plan data sharing decision to break down the silos of care is motivating, and that's really becoming the norm for any high quality SNF.
Got it. So beyond just sort of how Medicare may rate the organization, really looking at their capabilities above and beyond that may be a little bit harder to surface, but that's part of the job in terms of building a high quality network. Mary Ann, just follow-up question for you is, as you think about a high quality network being established, as a former physician executive responsible for programs like this, what are the expectations? If a member ultimately moves from acute, for example, into subacute or skilled nursing, what is a high performing partner really doing in terms of creating visibility and partnering?
Yeah, I think it's very important to establish expectations, to have a means of communicating with persons responsible at the SNF for providing the care. How I've always approached it is initially make connections with administrators or DONs, come up to an agreement for a communications plan, or care plan, or care coordination. In the beginning, I started with in-person meetings, and we transitioned over to Zoom. But honestly, the most success I've ever had is when we were able to coordinate electronically, in real time, bi-directionally, where you didn't have to take up someone's time to be having a meeting for a care conference, where we could have care conferences anytime about the patient, just in time when it was needed, rather than waiting for, like a weekly care conference with my care coordinators discussing our patient panel. So the ability to have folks on the other end who are active participants, engaged, willing to exchange information, answer questions back and forth is really key. And what we had done, because it's unfair to the SNFs if you don't set up expectations. is find ways to create care paths for certain disease states, the most common ones that we know that our patients were being seen for in the SNF, and have established milestones and expectations for where those patients should be at different points in the journey, so that we can control the length of stay, but also give some guidance to our SNF partners as to, what our expectations were in terms of recovery, or, the path back to wellness for our patients during the stay there.
So, it's more than understanding that your patient or member has moved into a skilled nursing facility. It's what's happening within the actual facility itself. I think that's probably a good transition here into some of the content here. We've got 3 specific views for those in the audience that we're going to kind of walk through. The first here is sort of a high level scorecard. This is an illustrative example of an ACO with, just a little north of 10,000 members. And just at a high level look, taking a look at skilled nursing facility utilization for the ACO members, but then also other post-acute care settings like LTACs and IRFs, inpatient rehab facilities. And so the red here is sort of showcasing on the slide perhaps a higher utilization compared to the ideal performance locally and nationally. And so that's just an indicator. But some of the things that people look at are, SNF use rate at present day relative to pre-COVID levels. I think it's important to kind of take a look at that time period and not take that into consideration in your overall management of your high quality network. And then also, what's the average annual spend per beneficiary? And then readmissions, of course, plays a role in that. And then I think, Marianne, some of the things that you were talking to in terms of like optimizing that length of stay. If somebody could potentially be in a skilled nursing facility for the right projected period of time, and then perhaps transition to home care or another sort of care setting, there's opportunity to optimize. And then the average spend here. So this is an example of one I would say that is maybe has an opportunity to really optimize some of their performance. Their average length of stay is about 27 days for a member. And their average spend per stay is about a little north of $10,000. So this is an illustrative example of perhaps an ACO that has a high performing SNF network that could be optimized. I do want to advance to the next slide. It's going to look a little bit similar in terms of its layout, but it's going to show you perhaps another scenario here where you have a high performing ACO with about 10,000 lives. So similar in size as the previous, but you'll notice that relative to the local and national benchmarks, that the average length of stay and the average SNF payment per stay is actually lower here. So about 22 days on average in a skilled nursing facility, and it costs just north of $8,000. So there is a delta. And I think one of the things that I would say is that this is in the blocking and tackling area. This is, I think this is the opportunity to kind of make an impact without feeling like you need to radically engineer something new. I think, Tina, as you suggested, most ACOs have put in a high quality network. I think, Marianne, where you're taking the conversation, being able to really have deeper visibility into what's happening in the facility creates an opportunity to optimize not only outcomes, but the cost as well. So I thought, just to summarize this part of it, let's take a look at those 2 ACOs side by side and what it ultimately means. The net delta here, when you compare the one that had the opportunity and the one that perhaps is performing a little bit better, is that there's roughly about a $3 to $6 million savings opportunity if you're able to ultimately optimize that post-acute care facility utilization. Again, looking at 2 equally sized ACOs with a similar sort of complexity and makeup on about 10,000 lives. So not insignificant by any means. And I think that this sets the stage for if as care moves into the home, these techniques that you're applying to things like skilled nursing facilities are going to be applied in the home care setting, which I think it's just a really important ACO muscle to have developed. I do want to, before we move on to that second strategy, Marianne, I do want to sort of just get your perspective on other programs that are available to ACOs in and around the skilled nursing facility environment. In particular, it seems like there's an opportunity with this emerging 3-day waiver.
Sure. So some of the ACOs on the line may already have this waiver. Basically, it is a waiver to help patients move from a home setting directly to SNF, avoiding the required 3-day inpatient stay. And we know many of our patients may have had a stay recently, and maybe it wasn't a 3-day inpatient stay, maybe it was an observation stay and they were sent home and they start to decline. That's a perfect patient to try to capitalize upon to use or apply this waiver. But there are also others who we may just be following in the home setting and they're starting to decline. And we know that if we don't take action, the next step would likely be an ED visit or hospitalization. So this is a way to more proactively manage care, avoid unnecessary higher cost utilization when appropriate and when safe. And I will say that over and over and over because I'm a physician at heart and a physician in practice. And that's the most important part, safe and appropriate. In order to utilize this, it does take some coordination. You will need to have engagement or participation by a physician or a provider overseen by a physician who'll be able to certify that the patient qualifies and obviously be able to examine orders and an H&P to that accepting SNF to make sure that there are no gaps or cracks that the patient can fall through during that transition from the home into the SNF. And appropriate diagnoses can be anything from cellulitis to some sort of antibiotic resistant, urinary related issue, exacerbation of COPD or CHF. It really is dependent upon the program and your level of comfort with both the SNF and with your provider's availability and skills in assessing that patient for appropriateness for transfer. But I do think there's a lot of opportunity here.
Yeah, very neat. And I know that this was introduced in 2021, so last year. So if I'm understanding this at a higher level, if you have an ACO member that had a acute, was inside of an acute care facility, transitioned to a skilled nursing facility, perhaps was there for 15 days, and then transitioned to home, with or without home-based services, this waiver creates an opportunity to actually have that member, if needed, and if it's clinically appropriate, I like that reminder for all of us, and safe, return them back to the SNF and not the hospital.
Yeah, absolutely. I'm even done this directly from the home setting for patients who haven't had any inpatient encounter, especially in the PACE world. We would utilize this approach often. We know our patients very well. We understood our SNF providers and were able to move the patient seamlessly back and forth, which honestly created a great level of satisfaction for the patients because they didn't have to have so many stops along the journey to get the care that we knew was needed. So high satisfaction, less stress for the patients and caregivers in terms of less sites of care that we were moving the patient through.
Yeah, fascinating. Thank you for sharing that perspective. I think, based on that last comment, it's probably time for us to move to our second strategy here, which is ACOs building a high quality care at home provider network. And, Tina, I know that in your earlier remarks, you talked about the broader trend shifting care to the home. But I just have a higher level question for you and our audience. Do most ACOs have networks of home-based service providers? And if they do, what types of things are they doing right now?
Yeah, we definitely have seen ACOs focus on expanding their home-based services. What's exciting is that a study that was recently published by the Institute for Accountable Care, the IAC, actually has data behind this now too. So listen to these statistics because I find it so fascinating. So 50% of the home-based care programs that have been developed by ACOs have been formed between 2017 and 2019. And when we compare that to, historically between 2014 and 2016, it's a much lower number. Only 26% of home-based programs were formed during that time. So if you think about that increase, it's double, which means our ACOs are in fact taking action. And of those ACOs that have been focusing on expanding their in-home care delivery, 2/3 of them are doing some type of in-home care that's that are true formal in-home visit programs, and another quarter of those are providing some type of occasional home visit. So this is definitely growing and maturing, and we anticipate that it will continue to over the next few years as well. There are remaining 17% that the IAC noted are focusing on actively developing some kind of in-home core service currently. So I think we're continuing to see the data support the trends that we know are happening as our ACOs work hard to care for their patients in this new way. What's interesting is that the types of in-home care that our ACOs seem to be focused on are typically right now in the primary care and any kind of care coordination, with programs that are maturing into also beginning to offer the transition of patients from a facility to home, addressing things like their social needs, delivering true hospital style of care at home. And so we expect those trends to continue maturing from an ACO core services perspective as well. In the IAC study that was published, the executive director made a quote that for anyone serving in an ACO to provide this kind of care at the home, knows firsthand that when a clinician goes into a patient's home, they're seeing things that you would not see inside the four walls of an office. And we know that when we understand how a patient lives and we get a better sense of what other factors are that are beyond just the traditional medical that are influencing their health, that we can take action on those things as well. So Marianne, something you mentioned earlier, the high patient satisfaction, I think that's a big part of this as well. Who wouldn't love the idea of this personalized care, that's very patient-centric in their home? And our ACOs are embracing that to deploy, more mature programs as well.
Yeah, Tina, fascinating. I mean, wonderful data to share with our audience here. I guess, Marianne, that leads me to a question for you. Maybe it's a little bit more pointed, but in our previous strategy, the first one was really getting a handle on your high quality SNF partners and having visibility into that care. I think, Tina, you've set the stage for, we need to replicate that concept and extend it into the home. And that needs to include home health and palliative and hospice and non-medical home care. There's an explosion of things that can happen in the home. But Marianne, for you, two questions. One, how do you go about identifying a high quality partner and who's most important, I guess? And the second is, does it really matter, I guess, at the end of the day, in terms of quality, if your focus is on just optimizing cost, is everything in the home just naturally going to be less expensive than what's happening in a skilled nursing facility? It's a question that we often receive in the market. I'm just curious on your take.
Or maybe I'll start with number two. Quality always matters, first and foremost, both to improve outcomes and also for patient satisfaction. And let's face it, the higher quality providers are usually better utilizers of services and aren't going to inappropriately provide services that are not necessary. In terms of the home environment, other than the services you've already mentioned, the ability to provide in-home radiology studies, laboratory draws. Those are often great satisfiers for patients, especially those with limited mobility or those who don't have easy access to transport or may not have great access to caregiver support, that we can bring those services to those in the home, but they can be variable. So you really do need a way to try to assess those providers based on both feedback from your members or patients, as well as your own experience of care in terms of turnaround time. So when you do request a service from them, how quickly are they delivering it? Are they delivering it in a satisfactory manner to that patient? Are they getting the results back to you in the time that you would expect it to? Are the reads or results appropriate? Are they actionable? Do they seem to make a difference in the care of the patient? And, I know we have up on the screen here many others: medical equipment, personal care, medical supplies, home modification and meal delivery. All of those are important at different points of the patient's journey, but most of them don't have a rating or ranking system. So you need a way to start to develop your own proprietary ranking so that you really can understand who are the higher quality performers in your geographic area. I will say sometimes you are limited by geography. So depending on where your patients and members live, you may be in a situation where you have limited access, to a few number of providers. And that's when you need to take some additional effort to really partner with those providers. Again, set expectations. It's the same story, and have them understand what it is that you're looking for your patients and members. And as a follow-up, check back in with those patients to make sure that what those providers promised to deliver was actually delivered and when it was supposed to.
Yeah. So I think we spent a little bit of time on that previous strategy looking at a sort of a utilization matrix around skilled nursing facility care. Seems like for home-based services, that's going to be an important piece as well, whether it's the number of visits or the types of assessments and the expected type of the expected type of outcomes that you're expecting based on activating that home-based service, maybe even tracking whether they're utilizing that 3-day waiver program as well. So what's the return from what are their admits to skilled nursing facility, which it would be a new concept. I think that could be important here as well. Fascinating. So we're getting a handle on skilled nursing facility utilization. We're thinking more holistically about home-based services and who are all the different providers and how do we understand who our partner should be and what the usage looks like. I do want to shift to the third strategy here, which is really establishing a connection with the member at home. And Tina, this is a place where just given the work that you do in the market, what are your provider, ACO, and plan customers doing in this particular area?
Yeah, I feel like most teams these days do have some sort of variety of RPM in place. And when we use the words, we see RPM or remote patient monitoring everywhere these days. But when we peel back the onion a little bit, there are actually a whole lot of different options within RPM that a team can provide to a patient. And so it's really important to understand that I think right now, a lot of teams are saying, all right, let's deploy an RPM kit to our chronically ill patients. And that's great. But it's really only a small majority of needs that are being met in that way. And I think it's important to recognize that, JAMA actually just published a study on this that highlights that RPM is not effective on its own to improve a patient's outcome. True effective remote patient monitoring needs to have the structure of a strong care team engaged daily with a patient to really understand and be communicating about the variables that are impacting their vital and telemetry information. And, something that we always encourage our teams to really think hard about is that we've got to move beyond the basic vital sign information that's a part of RPM and do more than that. So in other words, for our patients that are dealing with CHF among other conditions, we need to ensure that we get their telemetry data as well and other important information that RPM can support so that that is valuable and timely for the care teams that are truly helping these patients, try to stay in their home and out of a SNF or, any other kind of acute care setting.
Yeah. Marianne, curious on your thoughts, just from a practicing provider perspective here.
Yeah, and this is probably one of the most important points I think that we can raise. And I agree with you, Tina. RPM is great for objective data, but it doesn't really give us a full picture into what's happening outside of that data that's being collected with those devices. It doesn't tell us if the patient has food in their refrigerator or if they can get up to make themselves a meal, if they're toileting appropriately, if they have caregivers in the home to assist them. There's so much more data that we need to be able to collect that can't be collected through a device. So I think that we need ways to keep in touch with the patient. And I've said this at the beginning, I believe, and I'll say it again, not just during times of post-acute episode recovery, but also, throughout their chronic disease management life cycle, as well as when they're well, to keep them well and keep them connected to appropriate care at the appropriate time. One of my big pet peeves as a physician is we often plan care plans around or about a patient, and we don't include the patient. I can't tell you how many times I've had a patient come back and say, nobody asked me if I would be agreeable to that, because that's not going to happen. It's not realistic. So keeping connected to that patient in ways other than just the devices. So whether it's through a HIPAA compliant texting mechanism where you can interact with them, query them in terms of, how they're managing their disease, send recommendations to them, check-ins to see if they are ready to schedule their annual wellness visit, vaccines. I think really keeping that patient at the center of the care is key, but you have to do it in an easy way. Patients don't necessarily like logging into portals. I don't like logging into portals. I know yesterday I needed an answer from my healthcare insurance company, and I called on the phone, old-fashioned style, but I didn't feel like creating a username and password. I just wanted a human to give me an answer. With automated check-ins, though, you can be checking into multiple patients at the same time and only having to interact directly with those who actually have a need for an escalation or have a question. So it allows for you to put out a broad net and really only capture those who are actually in need of your attention at that time.
Yeah, great point. I think both of you raised great point. I mean, there is a time and place for those wonderful remote patient monitoring kits that are on the market. They're very cool, but it seems like they have a specific use case and it's not mass market. We need a strategy for ACOs that's holistic, that is the right tool and engagement model at the right time. So, I think building on that last point, Marianne, I think that takes us to our fourth strategy here, which is really supporting the ACO care management or operations team with a scalable approach to management by exception. One of the things that I hear often in the market is a lot of head nods when we're talking about remote patient monitoring and in-home services, and all this increased visibility and tracking of what's happening outside of a traditional healthcare setting. Very rarely will anyone push back and say that that's not a good idea. I think what people are most concerned about is, what will they do with all of that information? What if they miss something that's critical? And so, Marianne, I know that you have some experience in this particular area. I'd love for you to share with our audience, what is management by exception really, and how does an ACO start to effectively think about their universe expanding beyond what they've traditionally been doing to date as care moves into the home and community?
Sure. So, as I mentioned, with that broad net, being able to cast a broad net to interact with as many members or patients as possible, and to receive feedback from them in real time, and then to be able to prioritize just those answers that are in an outlier fashion that can be escalated to a team member who can take action. One of the biggest frustrations for my teams in the past, whether they were nurses, social workers, is that they spent a ton of time just making phone calls and not actually reaching anyone, or playing phone tag, which is dissatisfying both to the medical team member as well as the patient. In this fashion, you can do an automated check-in with numerous, and we've been able to show that when we are enacting automated check-ins, 75% of our members respond and remain engaged throughout the timeline of those check-ins, which I think is pretty interesting and amazing. I don't have the head-to-head numbers with phone interactions. I could imagine it's less, but I don't want to make any assumptions. And that of those that are responding to our queries, only 3 to 7% are requiring escalation to a team member for action. I know we always do hear about what if we miss out. There's always the possibility in that messaging back and forth to the patient to advise them to seek a higher level of care if you're not able to respond in the time manner that is necessary for their care. In other words, if their care is requiring a higher level of attention, then we redirect them to care. If you can plug into these members during those escalations, you may be able to align them with a telehealth visit in real time to prevent, any further deterioration. I think this is satisfying for the team members doing the reach outs because again, they're able to direct their attention to those critical few that really need attention, rather than feeling like they're spending a lot of time spinning their wheels and not interacting with anyone who actually needs or wants their help. I know that's one of the biggest complaints I hear. I have tons of friends in the healthcare industry, fortunately, and one of the biggest complaints we have is when we feel like our time is being wasted and we're doing activities that aren't adding value to the patient's lives. every healthcare team member wants to do a good job. Every healthcare team member wants to have interactions with patients that are meaningful and produce some sort of benefit. And I feel like this is really a way to help them, both the team members and the patients, to stay engaged with one another in a non-overburdening way.
Yeah, fascinating. I mean, Tina, from your perspective, and I know a lot of what you're doing with HealthLink is advising organizations on their technology strategy or approach. So a lot of what Marianne just described, it sounds like there's a technical component to making sure that it's easy. So from your perspective, what do you think ACOs need to be thinking about to deliver on the experience that Marianne just described?
Yeah, I think back to the analogy you gave, Ashish, about the care traffic control a few minutes ago, and really building out technology that enables our care coordinators to have their hands, on the data in a care plan for a patient holistically. So that means if there's a care plan tool that a team is using outside of an EHR or in addition to, then it's so critical to get it integrated. Marianne mentioned, earlier as well, that you've got to have this bidirectional data feed. And the answer is yes. We both cannot say that enough. There's data that we need to account for that's recent, same day information that our care coordinators and care teams need and should have at their fingertips available to them to take action on if needed, right, for that patient. And that's much more effective than relying on claims data. So it's critical to make sure that, as you're doing your IT enablement plans for any kind of new care delivery or expanding into the home services, that you've got all of your data that's coming in and accounted for, and that it's integrated and feeding into a one enterprise-wide care plan that the team can use holistically to serve the patient.
Yeah, it's a great point. I guess it brings us to the summary here of the 4 key strategies. And I think we started today's discussion really talking about the broader macro trend of shifting care, or maybe not just shifting, but activating care at home as now a new option that is really starting to take form in the industry. And so, yes, care is moving into post-acute care facilities like they always have. You need to have good partner networks there and visibility into how people are doing relative to the expected journey. Care is moving to the home. So in addition to those skilled nursing facilities, you need to start thinking about what are all the different home-based services that you need to organize into a high-quality network. How will you think about what's important to your ACO in terms of measuring whether somebody's actually performing like a high-quality partner, and what data are they sharing back to you, whether it's assessment data and or utilization data around their particular services. But it leads us to the 3rd strategy, which is there are going to be moments where your member is not in a skilled nursing facility or not being seen by a home-based provider, but they're unattended, if you will. And it's very important for you to establish a direct connection to that person in their home. It sounds like for the chronically ill or the medically complex, it could be some sort of device connected RPM kit. But Marianne, I think what you highlighted, I think was really critical. There's an opportunity to really, with a very lightweight model, establish longitudinal connection with the member on just their overall healthcare journey to drive awareness. All of that is great, but if we don't make it easy for the ACO operations team to not be overwhelmed by all of this information out in the home and community, but actually help them separate the signal from the noise, if you will, or pluck out the needle from the haystack, it's really not going to be accepted. And so I think, Tina, your final point here around making sure that the management by exception experience is integrated into whatever the ACO operations team has adopted to date is critical, because I think what we're talking about is a new source of data, not necessarily a brand new system per se. So that integration into that care management or pop health infrastructure is really critical. Before we move into the wrap up portion of it, just wanted to say thank you to everyone for taking the time to join us today to really explore this really important topic of care moving into the home and the impact to ACOs like the ones listening in today. Tina, thank you again for all of your remarks, and Mary Ann for taking the time to share your experience. We've certainly enjoyed the discussion. We will be sharing all of our contact information. I know that this is being recorded and will be distributed as well. There's a lot of opportunity here, and I know that in the foreseeable future, care is going to happen in high quality facilities like it always has. Now, increasingly, there's an opportunity to engage online, but now care can be delivered to you in your home, and the home as a professional site of care when it's safe and reliable. Mary Ann, I think you really ingrained that in my thinking. So it's important to start to embrace it and make sure that you have, as an ACO operation, visibility and connectivity into what's happening in that particular care setting. With that, I do want to open it up for Q&A. I think we've got a little bit of time. We can certainly take a few questions, and if we can't get to them all, like I said, we'll make sure that we have a written response sent out with the recording. There is as the answer or the questions come in here, one that has come through here, maybe I can just, I'll play the role of sharing the question out. But the first here is, how do ACOs leverage existing investments in care management systems and current population health investments to implement these strategies? You know, I'm happy to start with that, and then Mary Ann and Tina, feel free to chime in. But I think it's really critical when thinking about these strategies that this is not the implementation of a new system. I think if I reflect back on my experience with ACOs in particular, great work has been done to get a handle on building registries or member risk stratification models that understand who's high risk, low risk by program, by utilization. Really good stuff there. I think a lot of ACOs have done a good job getting their hands on not only administrative data like claims, but also EHR data, in particular from acute and ambulatory care settings. So that's wonderful. I think the third is they've also adopted technology that'll let them know when their particular member has admitted into a hospital that may not be a part of the ACO. So I think some really great innovation and work has been done to date. I think it's important when you think about these strategies as net new data to bring in and enhance all of those solutions that you've already adopted. So by no means do I think these 4 strategies compete with anything that's been done, but I think your point at the end there, Tina, around integration, it's important to get data from post-acute, from the home, or directly from the patient to flow into the existing care management and pop health infrastructure. Tina or Mary Ann, anything that you would like to add to that?
No, I just agree. Oh, sorry, Tina. The flow is important. I can tell you, I've been in situations where I was trying to interact with multiple different providers and sites of care, and I had to have logins, like 10 different logins to 10 different EMRs just to get information of my patient that I needed to then compile and put back into my own. So we need to make it easy for the providers and folks that need to do this work, because one more thing may just be that one more thing that pushes them over the edge. You know, we, again, talking about the staff burnout. So integration and flow of information, easy access to connect multiple systems so you really can see across sites is absolutely key.
Yeah, I was just going to add, there's an opportunity to optimize. And Mary Ann, this piggybacks on what you were just mentioning. I think when a lot of teams were implementing any kind of pop health or care management tool over the last, 5 to 10 years, we were really focused on setting up roles inside those tools that mimicked the kind of care team that existed across an organization. So for instance, our case managers were looking at a certain set of data in a care plan, and that was not the same information that somebody in an ACO may need, right? And so nowadays there's this opportunity with more care moving into the home to optimize our data sharing techniques in a tool that you're already using so that those care team members, regardless of their focus across an organization and how they serve a patient is going to be the same. So when I was mentioning earlier that one enterprise-wide care plan, that's exactly what I was referring to. Look at the way that your team roles are structured inside your platforms and change those so that you can all adequately see the most important information that is in a care plan for any given patient you're focusing on at the time.
Yeah. The next question here that's come through, and I think it's actually a wonderful question. You know, we're talking about this shift to home-centered care and the impact, but we didn't necessarily address this topic in this discussion. But the question is, what role do you foresee hospital at home, so the CMS hospital at home waiver program, playing in the future of ACOs? So it's an interesting question. Now, just for the audience, just to kind of level set, there is an opportunity for some diagnoses and procedures that need to be performed to actually admit somebody into their home and deliver acute level care at home. So Tina, I know you've spent a lot of time thinking about hospital at home. Maybe you can take the first shot at this one.
Yeah, I appreciate it. I think the thing that is going to be the biggest driver for our ACOs in true hospital at home care is the willingness of the plans that ACOs are serving to negotiate reimbursement models beyond the CMS reimbursement waiver that exists. And I think all of those things are really driving us to reevaluate the agreements that we have in place and innovate around some things that we could be doing together. And I think there's also the opportunity to take advantage in a new way, maybe some of the strengths of, say, payers in the local market as well, to enhance the type of, in-home care that a patient is receiving in conjunction with, with your teams and the health systems that you're serving as well. A lot of their areas of strength are in, say, behavioral health and palliative care, and maybe that's an area that the team can bring together and work as one and create an entirely new reimbursement model, in conjunction to serve that patient in the best way possible. So I think there's a lot of opportunity to innovate, and I see the CMS hospital at home waiver criteria pushing us more in that direction over time as well. We do anticipate it'll be extended.
Yeah.
Yeah.
Another place where that visibility and tracking will be important. So as
Absolutely.
SNF level care is delivered at home, ACOs need to be aware of it, and they need to understand how it's going.
Absolutely.
That there's another question in here that sort of builds on the execution of that, but it's just really how challenging is it to coordinate all of these providers and services across the different home health agencies and skilled nursing facilities? How do you make it all work? And Marion, I definitely want to pull you into this, but this is easier said than done. I think just based on my experience, but that's why companies like Dina, for example, are really in the space, is to try to simplify how you bring those providers together, learn as much information about their capabilities, keep it current, but then also enable them to share information efficiently. But Marianne, I know that your whole role at Jefferson was this for a good portion of time. So definitely want to give you an opportunity to comment on it.
Sure. Again, the information needs to be visible to all in an easy to access manner where you're not logging into multiple portals to share information. In full disclosure, I used to be a Dina customer in my prior role, which is one of the reasons that I was excited to work with this organization, because of their ability to coordinate multiple providers from disparate settings on one platform, so that all of those communications can be viewed by the different players involved with that patient care, and everyone be kept in the loop in one discrete area for viewing. It could be viewed on the go on a mobile device. You can communicate in the platform on your mobile device. So, I found that very easy for my team to utilize and really interact with, and it was helpful and avoided phone calls, faxes, texting, which were probably not HIPAA compliant like they should be, in reference to patients, but everyone could see the communication that was happening about those patients and, the timelines along with which that was happening.
Yeah. There's a couple of questions here that have come through, and I'm going to kind of take them a little bit out of order, but one that talks about, it's really, I'd put them in the interoperability category here, but smart home device manufacturers are starting to standardize a common platform for data from devices. So the Matter protocol. And the question is really, how impactful will this potentially be to make data interoperability easier to realize between different provider teams interfacing with the care and the patient? And so I'm happy to take this. I've spent quite a bit of time in the interoperability space. I think initiatives like this are fantastic. I'm in full support of all of them. I do also know that over the last 30 plus years, there is a whole community that is focused on just this, trying to drive standardization, whether it's around how do we transport the data securely, or what is the format of the data that's being transmitted, or how do we make it easier to establish these connections? So it is a journey. And I think that any solution is going to really have to support, much like what happens in the everyday consumer world, they have to support the standard, but they also have to have some level of backwards compatibility so that nobody's left out of the conversation. That's one of the biggest challenges with interoperability, is that not everyone's on a uniform upgrade or adoption cycle. So you're going to have this mix between analog and digital that needs to be sort of accommodated for. So the key, I think, is to make them all work. And I guess that leads to the second question here, which is specifically around hospice, but there's a broader point that I think we can make here. So with the importance of providing high quality care and reducing costs, how important does the role of hospice care play in your area? Wouldn't early identification of patients that might be eligible save costs and potentially reduce hospitalizations? It's a fantastic point. And not just hospice, but palliative as well. And I think one of the things that we have seen is that hospice is a very challenging conversation to have, first of all. There's a lot happening with patients and families, but we do see that length of stay is not long enough, actually. So that means that people are not being identified early enough to start that conversation. And that's also leading to difficult outcomes. You may see someone getting recertified on home health unnecessarily when the data is actually suggesting it should be in palliative or hospice. I think that's the value of data interoperability. That's where I think a little bit of the differentiation and magic happens, is the predictive models when all that data comes through. Marianne, I know that this is something that you spent a lot of time on. I want to give you an opportunity to comment as well.
No, I agree. I mean, the data is there, especially when you have home providers interacting with the patient in their natural setting and observing perhaps a decline over time, or really getting to know that patient better and understanding more of their goals of care and their wishes. So we need to find ways to gather that data that may be getting entered into assessments during a home health evaluation, OASIS, MDS, pull that out and present it back to the ACO care coordination team for identification of those patients, so they can delve a little further and interact with those patients to really understand the patient's goals for their journey, their understanding of palliative or hospice care, to identify it early. I agree with you. We don't do a great job with hospice identification, and you're right, the length of stays are short, which is what gives, I think, the general population sometimes a poor view of hospice, because they see it happening at the very, very end of that patient's life cycle, when there was so much opportunity to identify and initiate early and avoid that endless cycle of repeat hospitalization, causing that patient really pain and suffering along the way.
Yeah. I think we have time for one final question, and then we have to get to a wrap. But the question that's come through is, will all of these optimizations ultimately enable home-based service providers to be notified should something happen to the member that they're caring for? And the example that's cited is, if somebody's admitted to the emergency department, but the next day they have home health and meals and durable medical equipment scheduled to be delivered, that's a big coordination challenge, and it can create lots of problems. And I think from our experience, there are lots and lots of challenges like this. Tina, I know that you're looking at care logistics as a broader topic and theme. Maybe want to give you an opportunity to comment on this too.
Yeah, I appreciate that. I feel like this is the next big core area that I think a lot of ACO teams, and really any team moving into maturing their care at home, services will need to address. And it's really how to automate the supply chain to help support their teams remaining efficient, but also ensuring that their patients get everything they need quickly to be safe and comfortable at home. So I feel like this is a very relevant topic. And this is where it's really important to find a great partner that can help support you in doing this. So be aware, this is a gap, I think, in a lot of technology platforms that are out there. So look for partners in your area. This is a strength of Dina, who can actually help you automate this and address to save your team and some quite a bit of time, and to be able to get to the patients what they need when they need it, and to support them in staying out of the acute care setting.
Well said. Thank you for your comments, Tina. We're at time. Just want to say thank you to the Florida Association of ACOs and all of their members for joining us today and for this opportunity to share our thoughts on this really important topic. And for Tina, HealthLink Advisors, for taking the time to share your insights from the industry, and Marianne, as always, for sharing the on-the-ground experience of what it really takes to make all of this work. So thank you again for the opportunity, and look forward to continuing the conversation online or offline, however you prefer. Thank you.
Yes. Thank you all. Take care.
Take care.
Bye.